Starting off with epidemiology. It's useful to know the mean age of onset, which is 55 years old. You might not be tested on this specifically, but as you approach clinical rotations, knowing the mean age of onset will help you with your differential when you have a patient who comes in with an essential tremor. It affects males about the same as females and is a very common disease in the United States. As for etiology, causes, most cases of Parkinson's disease are idiopathic. However, you aren't going to be tested on that. You are going to be tested on more substantial causes. So for example, the first, 5 out of 5, MPTP. MPTP is a neurotoxin, and it causes symptoms of Parkinson's disease because it kills the dopaminergic neurons in the substantia nigra. It was first discovered to have a link to Parkinson's disease in 1976 when a graduate student who was trying to produce a drug similar to the opiates produced a substance with MPTP as a major contaminant and injected himself with this drug and later developed Parkinson's disease or symptoms consistent with Parkinson's. Also, repeated head trauma. The prime example of this is Muhammad Ali, a famous boxer who later in life did develop Parkinson's disease. And lastly, post-encephalitic Parkinsonism, which is the development of Parkinsonism symptoms caused by a viral illness. So, for example, there was a strong association with post-encephalitic Parkinsonism and the 1918 Spanish flu pandemic. Next, on to the pathology. So, histologically speaking, what are some important points that you need to know about this disease? Well, I've got two. Both of them 5 out of 5. Number 1, you are going to see death of dopaminergic neurons in the substantia nigra pars compacta. What does that mean? Let's break it down. The substantia nigra is a brain structure found in the midbrain. So in the picture on the right, there's an inferior upward-looking view of the brain, and there's a transverse slice of the midbrain that's taken. If we zoom in on those slices, you can see on the top of these two images the substantia nigra, which looks like a dark stain running through this portion of brain. And in fact, that makes sense since the word substantia nigra means black substance. So there's this black line that runs through here, and it's stained black, or it looks black, because it has higher levels of neuromelanin, which makes it appear dark. Compare that to the slide, or the transverse cut section below, in a Parkinson's patient. The color is almost all gone out of that section where the substantia nigra is. And that's because those cells have died. Alright, point number 2, also 5 out of 5. Lewy bodies. Lewy bodies are an aggregation of insoluble protein found within the nerve cells in patients with Parkinson's disease. They are eosinophilic, meaning that they stain a little bit darker red, and they're usually round and pretty easy to pick up in a high-powered field. Next, into the physiology of this disease. So, as I said previously, the substantia nigra has dopamine-producing or dopaminergic neurons. As those neurons or cells die, there is a decrease in the output of dopamine. Thus, less dopamine feeds to the striatum, which means there's less of a stimulation of the basal ganglia, which means there's more of an inhibition of the motor pathways. Sounds a little bit complicated. Let's look at it. It will make more sense. Okay, this is a coronal slice of the brain. It's not completely anatomically correct, just because it's more of a merging of an anterior slice and more of a posterior slice together. But it's useful to draw it this way just in helping describe Parkinson's disease. We are interested in these structures here, which I've color-coded and matched those colors with this box diagram on the right. So let's run through what we're looking at exactly. First, the cortex, where the initiation of conscious movement begins. Then we have some basal ganglia structures the striatum, which is yellow, the globus pallidus externus, which is kind of a lighter shade of orange, and the globus pallidus internus, which is a darker shade of orange. Next is the subthalamic nucleus, the thalamus, and lastly the substantia nigra, with the lighter shade of purple being the substantia nigra pars reticulata, and the bottom darker purple being the substantia nigra pars compacta. Okay? So let's take what we've talked about, these anatomic structures, and build a normal physiologic picture to talk about what should happen. And then we'll add the Parkinson's disease onto it and show how Parkinson's disease makes it go wrong. And to do this, I'm going to use mostly the box diagram on the right. I think this is a good picture. If you can draw this picture out for tests, it's pretty useful, but not necessarily mandatory. Okay, I don't think most of your questions are going to go into this depth. Also, I should point out that there are multiple neurotransmitters in these pathways. But I'm not going to be talking about the different transmitters. I'm just going to be saying, is it stimulatory or is it inhibitory? And I'm going to use green arrows if it stimulates something and red arrows if it inhibits something. All right, first, the substantia nigra pars compacta. It produces dopamine, and it feeds that dopamine to the striatum. When it gets to the striatum, the dopamine, the same dopamine, don't think that there's a difference in the dopamine, the same dopamine acts on different receptors, different dopamine receptors for two separate pathways. And don't feel bad if you don't get this right away. You might have to watch the video twice. That's okay. There's the indirect pathway and the direct pathway. The indirect pathway uses or has dopamine 2 receptors. Dopamine has an inhibitory effect on the cells that have those receptors. Dopamine has a stimulatory effect on the dopamine 1 receptors, which the direct pathway uses. Okay, so don't be confused by that. Dopamine is produced, dopamine is fed to the striatum. There's two different halves or pathways in the striatum, and both of those pathways do different things with the same dopamine that it's given. All right. First, starting at the cortex, a signal is sent from the cortex to the striatum. From the indirect pathway, there is an inhibitory signal sent to the globus pallidus externus, which then itself sends another inhibitory signal to the subthalamic nucleus, which in turn sends a stimulatory signal to the globus pallidus internus, which then sends an inhibitory signal to the thalamus, and then a stimulatory signal back to the motor control areas in the cortex. Okay, a little bit confusing. That's okay. It's okay. We'll get through it. Now for the direct pathway. The direct pathway is a little bit simpler. That's why it's called the direct pathway. The direct pathway also sends an inhibitory signal to the globus pallidus internus, and then it continues with another inhibitory signal to the thalamus. The thalamus sends an excitatory signal to the cortex, and the movement is initiated. So, let's play around with damage or death of cells in the substantia nigra pars compacta and see what happens to our signal for movement. So if you remember back, this is where the problem happens. There's death of the dopaminergic or dopamine producing cells in the substantia nigra. So as this picture illustrates, the output decreases. And I'm going to stay on the direct pathway here just to make it so I don't have to flip-flop. There's a decrease excitatory signal to the direct pathway starting in the striatum. Because that direct pathway is not stimulated as much, its output decreases. So it decreases its inhibitory effect on the globus pallidus internus. Well, if the globus pallidus internus is not inhibited as much, it puts out a stronger signal, which is inhibitory, to the thalamus. That means the thalamus is receiving a large inhibitory signal, therefore its output is inhibited. It's decreased, right? Moving over to the indirect pathway. The indirect pathway also receives less dopamine. However, because these are dopamine 2 receptors, that means this pathway is not inhibited as much. Therefore, because it's not inhibited as much, it has a stronger signal come out of it, which happens to be inhibitory. So it inhibits the globus pallidus externus even more. And then the globus pallidus externa inhibits the subthalamic nucleus less. The subthalamic nucleus stimulates the globus pallidus internus more, and we're back to where we were. Okay? Does that make sense? So if you put those two together, those two pathways together, the ultimate result is an increased inhibition from the globus pallidus internus, and thus decreased excitation to the motor pathways from the thalamus, which leads to the symptoms of Parkinson's, like bradykinesia, difficulty initiating movements, and slowness, and rigidity, things like that. Okay? So now, does that last bullet point make sense now? Decreased dopamine to the striatum leads to a decreased stimulation of the basal ganglia or the striatum, whether it be a decrease in the stimulation of the dopamine 2 receptors or a decrease in the stimulation of the dopamine 1 receptors. Both pathways ultimately lead to an increase in the inhibition of the motor pathways. Pretty cool, huh? And lastly, just as a caveat, look, there's a lot more to this system than I was able to explain in this short amount of time. There's more pathways, and also there's more neurotransmitters at work here. So just kind of keep that in mind. All right, guys? Let's move on. Now on to the clinical findings in Parkinson's disease. I like this picture. Number one, because I like Muhammad Ali. Great guy. He's done a lot for racial and religious freedom in the United States. But he's also a well-known Parkinson's patient. So, looking at our list, the top 3 things that you really should know about the symptoms of this disease are number 1, a pill-rolling tremor. Take a look at Mr. Ali's hand, his left hand here. Can you see with this thumb and this first finger the motion of the pill-rolling tremor? You can just imagine it right there, can't you? Also, look at his face, a mask-like face, which just means it's difficult for him to make facial expressions, like a smile. Now another famous Parkinson's patient, Michael J. Fox, also a great guy. Notice how he also has a hard time expressing his emotions through his face. Parkinson's patients also have a certain kind of walk. You can almost tell Parkinson's patients just by the walk. This picture is a great example of that. It's kind of a hunched over, shuffling of the feet, moving very slowly, with oftentimes the blank stare. Other things that you'll hear of are the cogwheel rigidity, which is a combination of being rigid and having tremors, very small tremulous handwriting, postural instability, and Parkinson's patients also very often develop dementia. Okay, now into the treatments for Parkinson's disease. And I'm going to use this picture to help walk through how each of the drugs work. I think this is an awesome picture. If you want to download it, there's a link on the right side there that'll help you find it. So what is this picture showing us? Well, it's showing us a light purple colored nerve, presynaptic nerve, that is above a few light blue colored nerves. The purple nerve near the top is a different color because I wanted it to represent the sick system, or those nerves that are dead or dying or not functioning properly, essentially not making the dopamine from the substantia nigra, as we talked about just a minute ago. Okay, and then the blue nerves down below are those ones that receive the dopamine, and they are not sick or dying. So let's zoom in and take a look at levodopa and carbidopa. All right, we know that we've got a problem with dopamine. We're not making enough dopamine. We're not getting enough dopamine to where it needs to be. So why don't we just give people dopamine? Why don't we just give them pills or give them a shot? Well, the reason is that dopamine does not cross the blood-brain barrier. So if they took it by mouth or you gave them a shot, it would never reach the central nervous system and would never do its job. The Parkinson's symptoms would never change. So how do we get around that? Well, we give levodopa, which is just shortened to L-dopa in the picture. L-dopa is able to cross the blood-brain barrier. And once it does, it is able to be metabolized or transformed or converted into dopamine fairly easily through the enzyme dopa decarboxylase. Perfect. Problem solved, right? Well, not really, okay? Because this dopa decarboxylase enzyme exists and works outside of the central nervous system as well, which means that it would be producing dopamine in the peripheral body as well. And that would lead to a whole bunch of side effects, nausea, dyskinesias. It would make you not feel very good at all. So, to fix that, carbidopa. Carbidopa is a dopa decarboxylase inhibitor. It cannot cross the blood-brain barrier. Thus, the peripheral conversion of L-dopa into dopamine is slowed a little bit. Thus, the side effects are decreased without changing the metabolism in the central nervous system. Also, it has another benefit. Not only does it decrease the side effects, but it also allows more L-dopa to be available to be used in the central nervous system because it isn't converted peripherally. It's not wasted peripherally, okay? Along that same line, the COMT inhibitors, 3 out of 5. COMT stands for catecholomethyltransferase. It's another enzyme that degrades or metabolizes L-dopa and dopamine. So, thus, giving a COMT inhibitor, again, decreases the waste and allows more L-dopa to be used where it's needed. And there's 2 there, entacapone and tolcapone. And out of those 2 drugs, you probably should know that tolcapone is able to cross the blood-brain barrier. However, it has the side effect of possible liver damage. On the other hand, entacapone cannot cross the blood-brain barrier, but has less of a severe side effect profile. So next, the dopamine agonists. The dopamine agonists work by directly stimulating the dopamine receptors that are on the healthy nerves that are kind of starved for attention. Those receptors that aren't being stimulated by dopamine because there's obviously less dopamine available. So we're kind of bypassing that dopamine system and just directly hitting the receptors with these medicines. Pergolide, bromocriptine, ropenolol, and pramipexole are great examples of those. Next on the list, again, 3 out of 5, the monoamine oxidase B inhibitors, selegiline and rasagiline. The enzyme monoamine oxidase B is another enzyme that degrades and breaks down dopamine, thus leading to a waste of that neurotransmitter that we're so desperately trying to hold on to. So if we inhibit that enzyme, we're increasing the amount of dopamine in the system. And the last drug that I'll talk about is amantadine. Now, amantadine isn't really an important drug, clinically speaking, for the management of Parkinson's disease, but I'm giving it a 3 out of 5 because it's pretty important for your test taking. Amantadine is used mostly as an antiviral agent, but it also has a little bit of use in Parkinson's disease, where it acts to decrease the reuptake and also increase the release of dopamine. So putting those 2 things together, there's an increased concentration in the synaptic gap. Okay, so again, important for test taking for tricky questions, but not really important clinically. There's just better drugs to manage the disease. Alright, so I hope that makes sense. This has not been an in-depth review of these drugs. If you need an in-depth review of these classes or these little families of drugs, you'll need to look those up specifically. And I'll cover more detail about the mechanism of action and side effects, contraindications, and things like that. Okay, let's move on. All right, my favorite part of the lecture, the knowledge challenge, my opportunity to pimp. Okay, first question. Lewy bodies are what? Well, remember back, think about the picture. Are they basophilic or eosinophilic? They're eosinophilic. Next, what are they made of? Well, they're aggregated protein, primarily alpha-synuclein. And lastly, intracellular or extracellular? Okay, good job. Hopefully that was the answer you picked. Knowledge challenge number 2. Which of the following enzymes is inhibited by carbidopa? Dopa decarboxylase. Why is that important? Well, the inhibition of dopa decarboxylase means that there is less metabolism of L-dopa into dopamine in the periphery. And this cuts down on the side effects of peripheral dopamine and also increases the availability of L-dopa for the central nervous system. Okay, what about the last two? I just made up the first one. The dopamine decarboxylase doesn't exist. What about catecholomethyltransferase? Give me 2 examples of drugs that inhibit that enzyme. I think about the American gangster Al Capone when I try to remember these drugs and how to pronounce them. Entacapone and tolcapone. And they're important because they kind of work the same way as carbidopa. They decrease the peripheral metabolism of L-dopa, thus allowing more of it to be available to do its job in the central nervous system. And lastly, monoamine oxidase B. Give me 2 examples of drugs that might inhibit that. How about selegiline and rasagiline? Again, same kind of theory. We're preventing the breakdown of dopamine so that there's more available to do its job. All right, good job. You survived the pimp